Welcome to AETCM, the Emergency Medicine channel.
So I'll give you a case scenario where a 4-year-old boy has been brought to the emergency. The boy has been having frequent episodes of breathlessness since last 2 days. He's on inhalers already, but the breathlessness is not subsiding. So the mother has got the child to the emergency room. So
on reaching emergency, 4-year-old child.
Yes.
So we initially sent an assessment with our PAT triangle.
Okay.
And appearance-wise,
child is little bit tachypnic and sick looking.
irritable child.
Not irritable. He is okay, but he looks in distress.
Breathing part,
He looks tachypnic and he is in
able
respiratory
to
distress.
continue full sentence.
He's trying to speak sentences. He's trying to give partial histories, but he is breathless in between.
Okay, so circulation part was any parallel.
Circulation part, he looks, the color of the child looks okay, and he's sitting and with the support on his knees.
So after getting the PAT triangle, we get to know patient in respiratory component is affected.
Okay.
With patient is tachypnic and patient is able to continue full sentence, able to tell the history. And his non-case of is
If he's speaking too much, he's getting exhausted. So, but otherwise, he's able to say that he is having some breathlessness, and he's able to tell those history.
So he is able to tell the history and a known case of asthma with
He's a known case of, he's on inhalers.
So
since the age of 2.
So with this initial tensing assessment, we can classify the according to the resuscitation UK guideline of acute severe asthma, acute classification of severe asthma. We can classify the child in a moderate group.
So you're confirmed that it is an asthma. You don't want any other assessment to be done?
Yes, sir. Then we going to primary survey. Airway was
airway is patent. The child is talking. There is no secretion. There is no stridor or any other sounds.
Breathing parts.
The child is tachypnic with a respiratory rate of around 50 breaths per minute, and bilateral there are right side you are able to hear some audible wheezes. Left side the air entry is not that great, but there is no crepitations or anything.
Bilateral wheeze is there.
Bilateral wheeze, but left side you are unable to hear the wheeze properly.
Saturation, sir?
Saturation is 90% on room air.
90% in room air. Circulation part?
Circulation, heart rate 140 beats per minute. BP 100 over 60.
100 over 60. Disability, sir, full?
Disability, GCS is full score.
Normal mental.
He is normal mental. He is giving you history.
So from PAT triangle assessment and our primary survey, patient in tachypnic with saturation is less than 90. So we initially
it is 90%.
90%. So initially go on with give oxygen with using a face mask, or we can use non-breathable face mask. Our target saturation is 94 to 98% saturation. With this primary survey and PAT triangle, we can classify the child into moderate to severe asthma groups. According to the group classification.
Sure. Okay. So, on what all basis we will say that, okay, this is a moderate, this is a severe, this is a near fatal asthma or a life-threatening asthma. What are the clinical criteria? Let's start with life-threatening asthma or near fatal asthma. What are the key points to say that this patient is having a near fatal asthma?
Life-threatening asthma, according to Resuscitation Council of New Guidelines of UK, we can use patient 7 components we can use. One is mental status. So in life-threatening, patient becomes drowsy, exhausted, decreased response. Then next is saturation. Saturation is less than 92% on room air.
Okay.
Then next one is peak expiratory flow rate.
Okay.
Which is less than 33%.
Peak expiratory flow rate we will not be able to see in a patient with life-threatening asthma. Even if in the books they say peak expiratory flow, that we can't, how the patient will do a spirometry, a bedside spirometry. It is impossible.
According to guideline, it is less than 33%. Saturation is less than. Then patient chest becomes silent. Then cyanosis, hypotension. Then patient was not able to talk.
Okay.
These are the conditions.
Saturation?
Saturation less than 92%.
92%. Chest, anything in the auscultation?
Silent chest.
Silent chest. So you can see the vital signs. Vital sign, any hemodynamic compromise, desaturation. You start from the ABCD, that is the easy way to remember. A, if the child is unresponsive.
Unable to talk.
Unable to talk. B, breathing part, saturation and respiratory rate. Tachypneic, quite tachypneic for that age group. So we are above 40, above 50, depending upon the age group, we can say that
silent chest.
Very, very important. And saturation less than 92%. Like we always discuss, which is more dangerous, bradypnea or tachypnea? Bradypnea. So the child would have exhausted and he might be going for a respiratory arrest at any point of time. So tachypnea, bradypnea is more important than finally hemodynamic compromise. So any phenomenon, you will say that near fatal asthma is there. Then coming to circulation and hypotension, we have said. Then coming to the other next level of asthma.
Next level of asthma is severe asthma. In severe asthma, patient is able to talk, but he is not able to complete a full sentence in one breath.
Okay.
And saturation part, it is less than 92%. Then peak expected flow rate between 33 to 50%. Then patient tachycardia in age group is 2 to 5 years, heart rate is more than 140.
Okay.
More than 5 years, heart rate is more than 120.
Okay.
And tachypneic respiratory rate is 2 to 5 years, which is more than 40. And more than 5 years, respiratory is more than 30.
Okay, fine. So then the next category is the moderate asthma.
In moderate asthma, normal mental status. Then
complete to send sentences.
Complete patient able to complete the full sentence. Saturation is more than 92%, and peak expiratory flow rate, which is more than 55%. Then tachycardia.
Okay. Then mild form of asthma, completely stable, only maybe mild wheeze will be present. So these are the category. Now, why these clinical signs comes in for a patient with asthma? What are the reasons behind these clinical signs, whatever we have said? Pathophysiology, increased work of breathing. What are the reasons for increased work of
because of three conditions. One is inflammatory action, then bronchospasm, then airway obstruction.
Airway obstruction. And what is producing because of that? Why there is hyperinflation? There is decrease in gaseous exchange. So there is no proper gas exchange that is happening. When there is bronchospasm, there is no proper gas exchange. There is no oxygen that is being delivered into the tissue. So these are all the major reasons why these clinical signs comes in to this patient with acute asthma. So now acute asthma has come in. My question will be whether we can manage an acute asthma with an MDI or nebulizer is better. Not for this patient I am telling you. The common question is whether an asthma can be managed with the acute asthma exacerbation can be managed with an MDI or you need a nebulizer.
Both things are same efficacy.
Okay.
In moderate asthma, we can use a metered-dose inhaler and we can check with metered-dose inhaler, like we can start with salbutamol or albuterol with a pressurized metered-dose inhaler. First of all, start with moderate asthma. We can give every 20 minutes up to 1 hour.
Inhalers. Puff.
Metered-dose inhalers.
Metered-dose inhaler, how you can give in case of moderate to severe asthma, moderate asthmas or severe asthma. If the patient is able to take, you can ask them to take one puff every 30 to 60 seconds. Maximum of 10 puff. So you can repeat that. So you are telling about nebulization, 20 minutes. MDIs, you can ask them to take every 30 to 60 seconds, one shot they can take and they can look for a clinical response. If they are feeling comfortable, then they can repeat it up to 10 puff they can repeat.
In less than 1 to 3 years, we can give up to 4 puffs. 4 to 6 years, we can give 6 puffs. Then more than 6 years, we can give 8 puffs.
So approximately you can remember for any age group above 4 to 5, you can remember for this age group, we can give 10 puff of in a shot, like every 30 seconds you see how the patient is improving.
Then every 20 minutes we can reassess, and up to 1 hour we can reassess the patient.
That is when you don't have a clinical response initially, you cannot wait for 20 minutes. You can't wait for 20 minutes. See, the difference is that the nebulizer, it's a continuous process. But MDA, you're giving one shot. Maybe the patient needs further more. So like that, you can continue further shots. So that is what you can, every 30 seconds you can reassess and you can give. So that is the difference. So
every puffs containing salbutamol containing 200 microgram is the dose is there. Then after 1 hour, if the baby or child is not responding, then that moderate asthma we can classify into severe asthma. Then if patient is not responding, we can also add ipratropium bromide.
That is the second line management. Your second line management start with your ipratropium bromide. How to give ipratropium bromide?
Ipratropium bromide also you can use precious methyltose inhaler with a spacer. It containing 3 puffs you can take.
Okay, you dose. Leave it the MDIs now. You come to nebulizers. How you want to give salbutamol nebulization?
Salbutamol nebulization we can available is 1 respule contain 1 ml contain 5 mg. So in child less than 10 kg, we can take 1.25 ml, that is 0.25 mg in 3 ml NS and give nebulization. In child more than 10 to 20 kg, we can take 0.5 ml, that is
half of it.
Half of 2.5 mg. And child more than 20 kg, we can
5 mg.
5 mg, 1 ml.
5 mg can be repeated. That's what every 20 minutes you can repeat and see.
Up to 2 hours we can repeat.
And see how the patient is responding.
We can give ipratropium bromide nebulization which containing 250 microgram in every respirators.
So that is the initial 2 major nebulizations that you have thought of. Any role for IV salbutamol?
IV salbutamol, they are advising in severe asthma. There is
only thing is that tachycardia, all those things can occur. So 15 microgram per kilogram body weight is what is recommended, but not routinely being used. So just for the sake of completion, we are telling this. Now the next important thing, what are the other options for you?
Other options, if the patient in severe asthma, we can give salbutamol nebulization and ipratropium nebulization, followed by if patient is not responding, we can consider to give injection MgSO4.
Before that, magnesium sulfate, anything else? Steroids?
We can start on systemic steroids, oral prednisolone.
The child is vomiting, then you need to give IV. So IV hydrocortisone, what is the dose? And oral prednisolone, what is the dose? Oral prednisolone dose is less than 2 to 5 years, 20 mg you can give. More than 5 years, 40 mg you can give. You can remember 1 mg, 1 to 2 mg per kg body weight. That is
injection with prednisolone, 1 mg per kg IV.
Hydrocortisone, when you have to give, it is 4 mg per kg. 4 mg per kg. The thing is that this is an inflammatory condition. So you need to repeat further.
For 6 hourly, we can.
Every 6th hourly, you need to repeat. When you are giving in septic shock, it is a replacement dose. But here it's an inflammatory shock. So inflammation also, you need multiple doses. So you need to give one every 6th hourly, you need to repeat the dose. So the patient is vomiting and all, you can give 4 mg per kg of hydrocortisone. So that is the next step. So you have given salbutamol, you have given your ipratropium, you have given your oral or an IV steroid. We have discussed already, both have equal bioavailability, and hydrocortisone, prednisolone or any of these drugs can be given orally or an IV. Then the next option comes here is the
consider of the MgSO4.
Magnesium sulfate. Magnesium sulfate, again, dosing, some books recommend from 25 to 75 mg per kg body weight, but not more than 2 gram, which is the maximum that we give for an adult dose. So you have to give it as an infusion over 15 to 20 minutes. So magnesium sulfate is the next option. Still
they can move with methylxanthine included like
aminophylline.
Aminophylline doses, we can, if the a patient was not taken within 24 hours of this asthma exposure, we can give 5 mg per kg loading dose, followed by 1 mg per kg our infusion we can start.
Only in that pediatric asthma we leave it, but adults they might be on theophylline. So adult who is already on theophylline, we don't give the bolus dose. So that is one difference from adult. But pediatric, they will not be on an theophylline, but very rarely we need to start aminophylline also. And only thing you need to be very cautious, the tachycardia can happen. Even in magnesium sulfate, when you are giving infusion, cardiac monitoring needed to be done. So that is the 1, 2, 3 action. If everything fails, then what is the option?
Then patient will be goes into life-threatening asthma. In this condition, we can try with NIV, non-invasive ventilation.
Okay.
Then if it
non-invasive ventilation, the most important will be most of the bone HFNC, high flow nasal cannula, because asthma is more into type 1 respiratory failures. Type 2 we don't see usually unless and until it's a chronic in children. You can get type 2 when they are getting exhausted, when they are going for respiratory failure, you can see it, not like COPD. But maybe a HFNC will be an ideal option initially and followed by a non-invasive ventilation. But in pediatrics, HFNC is more tolerable for the children. And finally, if everything fails, you need to go ahead for endotracheal intubation. Endotracheal intubation, what will be the drug of choice?
Ketamine is the drug of choice.
Ketamine is the drug of
choice. When we can use rocuronium, followed by we can sedate with vicuronium.
We should be avoiding drugs which can cause histamine release. So the drugs which can cause histamine release, what will happen? There can be further worsening of asthma. So the drugs which cause histamine release, we should be completely avoiding that. And what is the problem that you can anticipate in a patient after intubation? You have done a pediatric intubation. Remember pediatric or adult, whichever it is. What are the problems that you can anticipate in a bronchial asthma intubation? One important thing what you need to know is the air trapping. Already there is significant bronchospasm and we are giving positive pressure ventilation. So there is no proper ventilation happening in here. So the air will get trapped inside the alveoli. So what does it called as? It is otherwise called as dynamic hyperinflation. The lungs will get expanded and as a result the patient can go into hypotension. Very common in adult bronchial asthma and COPD patients. Usually we don't intubate asthma children very frequently, but in adult intubation both for COPD and asthma, when we are intubating they can something called as dynamic hyperinflation, something like an auto PIP. Suddenly the air will get accumulated within the lungs, resulting in what will be the clinical deterioration that you can get during that time? You will have hypotension because the negative intrathoracic pressure is increasing and as a result decreased venous return and you will have hypotension. So one important thing when you have intubating a patient, specifically adult patient, you are intubating him and you are putting on ventilator, specifically in COPD and asthma, you need to anticipate this. So in order to prevent that, we can do certain strategies. What are the certain strategies what we can do?
The PEEP
we can keep the tidal volume on the lower side. Keep the respiratory rate little bit on the lower side so that the air trapping can be avoided. So these are the two things. Your target tidal volume may be 6 to 8 ml per kg. Maybe you can start off with 4 ml per kg and after sometimes you are giving nebulization and everything, the patient is improved, you come back and make it to 6 to 8 ml per kg. That is the thing that you can prevent dynamic hyperinflation. And another thing that you can do, once it develops, what you will do, you just disconnect from the ventilator for another 30 to 40 seconds. So whatever be the air that has trapped inside the alveoli will get released. So the hypotension will decrease. So what are our problem with suddenly think after intubation there is hypotension, we'll be thinking that whether it is a pneumothorax, we'll have definitely that suspicion whether it is a pneumothorax or whether it is hypotension or the drugs that you have used causing that hypotension. But you have to keep this in mind. This is one of the important thing that can happen for an COPD or a bronchial asthma intubation. Pediatric, we don't intubate them very frequently due to bronchial asthma, but adult definitely yes, we need to keep that in your mind. Okay, so that is your severe asthma management. Now let's come back to this. Whom all we should admit?
According to one pediatric respiratory assessment measure score is PRAM score is there. Containing 5 components is there. One is scalene muscle contraction, first component, then suprasternal retractions, then air entry, V's, next is oxygen saturation room air. So its maximum score is 12 for these 5 components. Then we can, with this scoring system, we can divide the patient into 0 to 3 mild asthma, 3 to 4 to 7 it is moderate, and 8 to 12 is severe.
Okay.
So child reaching emergency with a score more than 8, they require admission.
So without any scoring system,
without scoring system, we can give nebulization between inhaler. Patient is not responding, not relieving.
Moderate to severe asthma, definitely admission. No doubt in that.
Then
only into mild to moderate, that maybe the bridging between a mild or it's a moderate. Moderate to severe, there is no confusion. Mild or moderate. Mild asthma we can dispose, but mild to moderate, the child is unable to talk. The child requiring oxygen saturation is still there and the child is still tachypneic. His symptoms are persisting. And most importantly, what is the reason behind an exacerbation? What is the reason?
Triggering factors.
Triggering factors. What is the triggering factor? And additional infection is indicating for an admission. Most commonly a viral infection. Now, cold temperature. Now, slowly the cold temperature will start in November, December during that time. So, these are the common, and allergens. So, these are the common triggers. So, you see all those things and you take a call. Usually, moderate to severe, you need to be admitted. But every case of asthma needs observation. So that is the most important thing. Whether you're admitting into in hospital or thing, you have to have an ED observation for 4 to 6 hours. And you should see how the patient is improving from that. You can put any scoring system. But in a simpler terms, you look into the child and requiring admission where IV medications are needed, child is unable to take orally, and the child requiring frequent nebulizations, and the hospital is very far away from home where they can't bring back the child. So these are all factors that you need to consider. The guidelines will say a lot of things, but there are certain other factors also we need to be considering whether to be admitted or to not. Who need to be admitted to the ICU or HDU is very easy, or severe asthma, they should be in the ICU. Those requiring NIV, those requiring more than maybe 5 liters of oxygen requirement, and persistent V's after 4 to 6 hours, your vital tachycardia is persisting, there is some hemodynamic compromise, those all group to be admitted to the ICU or HDU facility. But the rest, you can decide whether to keep under observation, whether to keep inside the hospital, in ER or discharge. It all depends upon these factors. Okay. Now, what are the advice that you will give to the parent?
Parent advice is like avoid from the triggering factors. One is pollen. Normally it is normally in the winter season, so close the doors. If the pet is there which containing feather and fur, clean the feather and this. Then dust, mite, vacuum the and cleaning the bed sheets.
During this episode, what all the instructions that you will give to the parent? What all things when they should bring back the child to the hospital? You are discharging a mild case of asthma.
Patient, if the baby developed these things, we can start with the pressurized mucus inhaler. If it is not responding to this, we can take the child to hospital.
Okay. Then anything else? Any numbers? Any peak expiratory flow meter? What is it?
This is peak expiratory flow meter. Normally,
this is very good when we are discharging. In an acute situation, you cannot ask the child to blow into this. But when you are discharging the child and you can tell them, you need to give the chart and you need to tell them what is the percentile for this. At least 75% below if it is coming. For example, he should be having 500 ml of tidal volume. Imagine. So he is having 500 ml of tidal volume. 75% of around 350 to 400. So it is coming below 350. So that is the time they should bring back the child. So this is a very good device where you can give them and ask them to teach the parent. Very easy to do this also, and they can look at this and they can decide whether to bring the child back to hospital or not. In ED, we can use it for a mild to moderate. The child is not in distress, just staying, and we can calculate all those things. But in a distress child, it's pretty difficult to do. There are now automated ones, all the electronic ones all have come, where you just blow into this, within 2 to 3 seconds you will get the result. But this is very simple one, 500 rupees approximately. They can keep at their home and they can know when to bring the child to the home. Child to the hospital, because they can keep at home and see this, this target. Previously he should have 500 ml. He was doing that 500 ml. Now he is doing only 300 ml. So there is some problem. Even after giving MDA, there is no improvement. So we can educate the parent with this thing. So that is the importance of having a
child can make a peak exploratory diary every day, same time, morning and evening. 3 repeated time we can do, and maximum of the 3 one score is taken as the value. Then if it is decreasing by less than 75%, then
they can come to hospital. Okay. Anything else that you want to add on? Then there are a lot of scoring system for asthma. A lot of scoring, but be very practical. We can't remember all the scoring system. We should know what is severe, what is life-threatening. But mild, moderate, there are guidelines, they say mild you give only beta-2 agonist. Moderate you give add-on ipratropium with steroid. It all depends upon the clinical response. If a mild patient don't have clinical response for your initial beta-2 agonist, you will be giving an ipratropium, you will be adding a steroid nebulizations also. So it's all depends upon the clinical response of the patient. Don't just focus on the guidelines. This is a basic minimum thing that you should be doing. There is no problem when you are going little bit ahead and treating the patient. And always keep in your mind, treat the trigger. treat the trigger. The trigger should be treated like rightly pointed out. The home should be clean. The pets also. What are the reason? The most common reason is a viral infections. So that trigger you need to catch on from the beginning. If the child is not vaccinated appropriately, should tell them to vaccinate to the age because more prone to develop infections and all. Okay. Anything else that?
Then, if asthma patient require chest X-ray,
chest X-ray is needed.
Chest X-ray in 3 conditions is there.
Yes.
If the
that we didn't say about investigation. We didn't talk about investigation at all. That's not needed actually. Only when one is life-threatening conditions. Now, next one is fever. We cannot explain with viral infection. So rule out any pneumonia, bacterial pneumonia. You can take X-ray. Then other thing is patient is not responding with initial treatment. So we suspect any foreign body aspiration or any cardiopulmonary congestive heart failure. We can take X-ray. X-ray. Even blood investigations are not warranted initially. Maybe for moderate to severe we can, yes, but for a mild asthma, not even a blood gas is required during that time. Okay, fine. Thank you.
Thank you, sir.